Good. We're going to start. All right. Good. I can start. All right. Hi, everybody. We have a very impressive number of pre-registrants, more than 3,200. And I have the great, I would say, pleasure to present you to Professor Ibrahim Morgentaler, which I will be interviewing at the end of this lecture, about 1 hour and a quarter, 1 hour, 20 minutes later. Ibrahim, can you connect?
I think you need to make me host for a moment.
I've just done it, you're host.
Okay.
Okay.
Yeah, good.
Hi, Ibrahim. Ibrahim, you're the big pioneer behind the investigation on testosterone and prostate cancer. Can you say just a very short word about it? And you have done also a whole presentation in the model on testosterone.
Yes, well, first of all, thank you for having me join you in your educational endeavor, and congratulations on your great success with this project. It's a pleasure to be with all of your attendees, and I say hello from the United States. Hopefully everybody's health is getting better with the COVID now. You know, the story about testosterone prostate cancer is an amazing story of how science works and how it fails and how we have to move forward. It's really been a remarkable journey of discovery for me. And of course, behind all of it has been the importance of hormonal regulation, especially testosterone, for men, and of course, separately for women, but a lot of my research has been with men. And, you know, just very, very briefly, Charles Huggins won the Nobel Prize for work he did in 1941. He was awarded the Nobel Prize in 1967. And he started this belief that testosterone was very dangerous for prostate cancer. And at the end of his landmark paper, the final sentence says, testosterone injections activate prostate cancer. And it was largely because of his work and a few others that followed that the medical community was terrified of the idea of using testosterone in men for many decades, because we were all afraid it was going to cause prostate cancer and make it worse. And I believed all of it.
Here, so you'll explain the next part afterwards, because I think it's really fascinating, and it's good that you have the time to explain it also in depth, and I think we'll learn a lot about new things. So thank you. Can you disconnect again, in the sense that you make me host again, and you get out, because we have this little problem to arrange so I can get further.
Very good. So you're host again, and I'll see everybody a little bit later on.
Okay, thank you. Just disconnect your audio and video. Okay, good. I have a presentation I want to really present, and you will see that we're not only talking about men, but also women, and we'll start with women, actually. So let me show you my screen, and here it is. Oh, okay. So women, it's no need to say that women are extremely important in the world. Wouldn't be there if there were no more women. And testosterone is there a very important hormone to keep the health of women optimal. And we're going in the model that I'm presenting here and giving an overview. I'll give several clues on that. You will see how important it is to diagnose testosterone deficient in women, and also to be able, as a health professional, as a physician, to treat. So the actions of testosterone in women is to give her mental firmness, to give her physical firmness, and also to build up bones and muscles, for example, but also to have very important action on sexuality and on female genital areas. And these are just some of the actions of testosterone, but extremely, extremely important, because it can make a real difference in the life of a woman and her partner and her family. So androgens, male hormones, testosterone, being the most well known, are actually made in 4 glands: the adrenal glands, the ovaries, and there are also other androgens made like DHEA, androstenedione, dihydrotestosterone in these 4 glands. So it's not something just for men, testosterone, although it's called a male hormone, but it's also for women extremely important. You see here that plasma total testosterone in women at age 20 is about 21 actually is about 351 picograms per ml, but at 40 years it already declines by more than 50%, which is a major decline, because that can explain why there might be a lack of libido in women and a decrease in sexuality, but also much more, you will see. So what exactly is this syndrome? What are the complaints a woman has and the physical signs a woman has when she has this female testosterone deficiency or female androgen deficiency? Well, basically psychological. They will feel anxious, insecure, has to be reassured by a partner often, have difficulties to make choice. She will hesitate much more. And actually all these complaints are also found in men who are getting testosterone deficient. They can lose self-control quickly and may even have a sort of very emotional reactions that are negatively called hysterical reactions. And they may feel deeply depressed, and actually the most successful hormone to get a woman out of a major depression, in my experience, is testosterone. And you might need to give a slightly higher doses of testosterone, but testosterone is really very important there. And also they have then a lack of sex drive and orgasm. And what are then the physical signs? Well, I'm just going to show you some of those physical signs, but when you look at the face of a woman who's getting testosterone deficient, you see that the hair becomes dry and droopy hair, and you can even have hair fall out. I have women where I have succeeded in getting their hair back, the female pattern baldness back, by giving testosterone and a blocker of the conversion of testosterone to dihydrotestosterone. A pale face, lack of muscle volume, as you see here, and loose muscles. And the muscles of a woman, if she never had a lot of testosterone, can be thin, underdeveloped. Like in this woman, they're not so large actually, and it's mainly, but not only, due to a lack of testosterone, this one. And when women have had a lot of testosterone and then it declines considerably, they can have a fat accumulation in the arms and get those fattening of upper arms, for example, but also the fattening of the thighs, cellulite. So in the armpits also, when you look at the Wolfsdorf stages, which are the stages of development of the armpit hair, you will have women that will be in a underdeveloped stage if they never had a lot of testosterone and other male hormones. So in this woman, for example, that you see here on the picture, she is in stages 2 and 3, which are may point to a testosterone deficiency. And meaning that this woman also that has that type of armpit hair will also have the complaints, the psychological complaints of testosterone deficiency. And also varicose veins can be due to testosterone deficiency, because the walls of these veins are fragile, are hypotonic, and then they easily get into developing varicose veins that are not very functional. And I want to point how important it is to think when women get to have hysterectomy. And in some countries, the hysterectomy, the removal of the uterus, is done in more than 30% of the women, which is, I think, too much. And also when the ovaries are taken out, you get a great drop of androgens. So here, for example, when you have a woman who had hysterectomy without taking the ovaries away, they have, if it's done soon, before the age of 35, a 29% increase in all-cause mortality. So it's just not a benign operation to do it, because 30% increase in mortality corresponds to 3 to 4 years of shorter life. Now, when it's done after the age of 35, there's actually a decrease in mortality, probably because by taking out the uterus, you avoid some problems they have in the perimenopause, the period before the menopause. Now, when you compare this to women who have had hysterectomy, but the ovaries have been also removed, if it's before the age of 45, they have a 15% increase of all-cause mortality. So hysterectomy, okay, after age 45. Removal of the ovaries may be acceptable, but after the age of 35, 45. And you see that there's actually a slight decrease in mortality when it's done after age 45, because probably we're avoiding some other problems. But anyway, the message is don't do a hysterectomy too soon, and maybe don't do a hysterectomy at all, because it might not be necessary if, as a physician, the patient is treated to balance her hormones. And so interesting is to see that when you look at the women who have their whole life had intact ovaries and uterus, nothing has been removed, they actually have some male hormones declining, some increasing, which is not in most studies. Most studies, all the androgens decrease, but they do have a 30% increase of the SHBG. That's a protein that transports the male hormones throughout the blood. And if it's higher, it keeps the hormones more in the blood, and they don't go in target cells. So there's sort of androgen activity decline. Now, when you look at a woman with hysterectomy, they actually have a decrease in the serum total testosterone. So there's less testosterone than in women who did not have hysterectomy. And also another important hormone of the adrenals is declined, 30%. When you look at women who have not only uterus removed, but also had the ovaries removed, there's a more than 40% lower levels of testosterone than the woman with intact ovaries, and a 10% decrease in bioavailable testosterone compared to these women, meaning that these women are deficient in testosterone, and that's probably the reason why there's an increase in mortality. So you need to treat in women not only the female hormones, but also the male hormones. It's very, very important. So when we look at, for example, testosterone levels in women, well, in women who are very old, the lower the testosterone is, the free testosterone, the less skeletal muscle mass they have, the less they have what is called sarcopenia, a lack of muscles. So they won't be able to do all their daily activities, or to carry things, or to walk long. And also testosterone deficiency is linked with more overweight in women. You see, in all women combined, there's a 10% increase of intra-abdominal fat, the fat in the belly, over 2 years. If they did not have female hormone therapy, in those women, the lower the testosterone is, the free testosterone, the more there is gain inside of the belly of fat. So there's a fattening of the belly, of the abdomen, when there's a lower testosterone, and the lower the testosterone is, the more fattening there is. And also there's an increase of SHBG in these women the higher SHBG capture testosterone in blood, and it doesn't go into target cells so easily. So when you look at a woman and she has a high testosterone, she's likely to have this outlook that you see here on the right. When there's a lower testosterone, she's actually inclined to get more and more fat in the belly and get overweight. Now, also testosterone is extremely important for having women being continent, having no loss of urine. And when there's testosterone deficiency, there's a loss actually of urinary incontinence. This study, for example, shows that women who are in the lowest 25% of the testosterone are actually have 45% more risk of stress incontinence. When they cough or they have to run somewhere, they lose urine. And they have also 68% more risk of mixed incontinence, being also they have to go quickly to the toilet next to the stress incontinence. So that's very high. And I can tell you in my experience, by far the most efficient treatment to restore urine continence in a woman within 3 to 8 weeks is to put small doses of testosterone around the urethra, and the woman has then to do exercise, because that's the important thing. Testosterone works on a muscle and on a system of muscles and on sphincters on the condition you do exercise on the places you want to improve, and you put testosterone nearby or systemically by having it coming in the blood. Now, what about breast cancer? Because everybody's afraid of cancer. It's mostly almost the same as for what Professor Morgentaler will talk about prostate cancer, is that testosterone deficiency can promote breast cancer. And there's not only one study. And I wanted to show you that breast cancer patients have low salivary testosterone. It's slightly lower, but even the DHEA sulfate, which is also considered as an androgen, a male hormone, 70% decrease, and estriol, which is considered as being a protective estrogen for the breast, are also lower in these women, but they do have higher levels of salivary estradiol and of estrone. And so that the ratio between salivary testosterone and estrone and salivary testosterone and estradiol decreases a lot. And that's important. High estrogens, low testosterone promotes breast cancer. So testosterone is one of the tools to counter that. And in the model, I will show several studies that show that it really is improved. When you give testosterone to women, you have less risk of breast cancer. Now, testosterone deficiency can also make women die earlier. And we know this, there are studies in women with disease, with low testosterone, they have a shorter life expectancy. But let's look at those longevous women, those women who become centenarians. And long-living women usually have high testosterone, and not just slightly high. For example, here in this study, a woman of Okinawa, that's the island in Japan where there are 3 or 4 more centenarians than an average Western country. Well, women of Okinawa, they have, at 70 years, have a low level of testosterone. Women of the United States, hooray, they have slightly more. But let's look at the woman in Japan, in Okinawa, that becomes centenarian. Their level is 39 nanograms per deciliter. So it's 3 times higher than other women of 70 years who probably don't live longer than the average of 70 years. Only the women with high testosterone live very long. And it's 2.3 times higher than a woman of 70 years in the United States. So if you want to spot which woman is going to live long, check testosterone when she's, let's say, 70 years of age, and then you'll have an idea. And if she has a bad and low level, why not supplement this one with testosterone next to the female hormones? Because there's always a balance between the two. And so we'll talk about how to make a diagnosis, but there are levels of testosterone in women within the reference range that are actually linked to disease. So this is when you have a lab test, there's a lower limit of young women, for example, an upper limit of young women, and a mean level. And these levels is the reference range. And there's 95% of women who do a blood test are between this reference range when they're young. The reference range of older women is lower because older women on the general have lower levels. And studies have shown that the pathological range is actually levels that are below the lower limit, but also in the lower half of the reference range. And so I will show all these studies, or many of these studies, in the presentation, so you will be well informed. But I'm going to go a little further. I'm going to show some of these studies. If a woman is in the lower 25% of the values, she's more or less in this range of values, she has more, and older women have more atheroma plaques, so atherosclerosis. If a woman is also in below the 1.2 nanomoles per liter, she has more coronary heart disease than postmenopausal women. Interesting to see is that some studies have shown that the average of young women is not at 50, but at 28 nanograms per deciliter. Also, another study for premature atherosclerosis in not only older, but also in premenopausal women, if you're in the lower tertiles, if you lower 66% of values that are presented in the lab. So most women are then having a high risk of premature atherosclerosis, and it's for this reason recommended actually to be probably on a higher level. And then you have also association, meaning that the higher the testosterone levels is, the less risk of the disease you have. So, for example, if they are in the lower part of this reference range, being the lower 3/4, for example, there's lower HDL cholesterol, high triglycerides, higher inflammation, coronary heart disease, premature atherosclerosis. So we have a lot of studies confirming that the reference range is what it always has been, a statistical range with 95% of patients within, 2.5% below, 2.5% above, and that you do need to make also good clinical investigation and take a decision to treat the woman, even if she has lab tests within the reference range. But if she's complaining and she has testosterone deficiency signs, it helps. It is a justification for treatment. So let's look at the treatment in women. Now, the treatment does not start by giving testosterone. The treatment starts by preparing the situation and taking everything out that may block a treatment or that may make that this woman doesn't produce so much testosterone. So here, the diet, for example, woman has to stop sugar, sweets, and soft drinks because that lowers significantly the testosterone level. For example, when you do an oral glucose tolerance test, that's 75 grams of glucose, that's equivalent to one big milkshake in the McDonald's, okay? So you take a McDonald's milkshake, what happens is that during a certain time after, there's more and more decrease of testosterone and other androgens like DHA sulfate. And what about coffee? Is that so good to take coffee? Well, we saw for the thyroid that coffee decreases the thyroid function. Well, it also decreases the testosterone in women. So you see here the caffeine intake. The higher the caffeine intake is in postmenopausal women, the lower the serum total and bioavailable testosterone is actually. So there's an inverse association. So this means that the more coffee you drink, the more lower the testosterone is as a woman. But you could take decaffeinated coffee where you probably don't have that effect. So there's an alternative. And what about those oral birth control pills? Those are miraculous pills. They can block ovulation. I find it a fantastic discovery, but the problem, it depletes women of a lot of testosterone. For example, you have a new pill on the market. I'm not going to name the name, but it's made to make women more feminine, okay? And then the thought is to make women more feminine is not to give more female hormones, is to give actually something that blocks the male hormones. So this hormone blocks the male hormones. And this birth control pill, and you have a 62% decrease in serum total testosterone. So a decrease of one of the most important hormones for women to live long and stay healthy. And an 86% of decrease of the serum free testosterone. And it's the free testosterone that is most available testosterone for the target cells. So the target cells get very depleted in testosterone. And the SHBG, which keeps the testosterone in the blood, is fantastically increased by 3.5 times a higher value. So it keeps the testosterone inside of the body. But this pill is even more disastrous because it blocks androgen receptors. So if it's, I would reserve it to the very few women who have a very high androgens, but not to the women who have normal androgens and have some masculinization signs or acne. So the progesterone here blocks androgen receptors, supplementary to all the other effects. So there's really very poor activity, and these women become easier depressed and have cellulite easier and things like that as consequences. And it's also the case of many other pills. So there are ways to arrange that. You can give a pill, but you need to supply the missing hormones. Now, testosterone treatment itself, to treat this sort of androgen deficiency, there's a golden rule. And the golden rule is that you need to have a balance between the female and the male hormones. So you need to counterbalance if you give testosterone with female hormones. And the female hormones might be estrone, estradiol, estriol, progesterone. Usually it's estradiol and progesterone, and maybe estriol. And so you must always supply, there's really a golden rule, estrogens and progesterone when testosterone is supplied. And so we'll talk about transdermal testosterone. I won't talk too much now here about it, but also about intramuscular testosterone injections. And I'll say a little word about that. Is that it's worth in someone to give testosterone injections because the contrast can be very strong. And it's testosterone enantate or cypionate that I would propose. Dose is between 50 to 150 milligrams per month. 150 is a lot, so 50 and 75 milligrams is the most usual dose. And the frequency is to give it sometimes in divided doses, in generally once times per month, but someone will take a very, very small dose every 2 days or once a week. So they divide the dose over time, and that gives even a better effect. And in that case, I usually always apply with finasteride. It is this non-bioidentical progesterone derivative, but it works well. The dose is between 2.5 to 10 milligrams, which is a high dose, but it's well tolerated. I have a large experience in that when you provide testosterone in women. Besides, I would never give finasteride, not to a man, not to a woman, without testosterone. So never give it without testosterone. There can be an atrophy of genital areas by decreasing too much of dihydrotestosterone. They can even, there's some anecdotal studies, they could even promote stroke. So I wouldn't do that. Always finasteride, always testosterone when you give finasteride. So I will talk about how to adjust the doses to sports, to being bedridden, to stress situations, or to decrease the dose. And let's very humoristic look at some of the overdose signs. Women can be overdosed in testosterone, and that's also not good. They could have this sort of excessive aggressive there where they talk, did you say aggressive behavior? You see this woman being very dominant also. And there can be also physical signs and of the hydrotestosterone excess, and you probably are already suspecting what I'm going to show because I'm doing chunks of humor. Now this woman said, now I finally have a good sex drive since she went and took testosterone, but yours has become poor. So I will explain how to avoid these problems because some women are more sensitive to testosterone, and you can know it in advance. There's some testing you can do to know if that woman will badly react and go and get these type of overdose signs. Then I will talk about diseases where you need to adjust the testosterone treatment. I will show that testosterone treatment can improve the mood in women. They can make this woman determined, women who are hesitant, anxious, and then become with testosterone self-assured, strong, determined. They know what they want to do. They will do this, and they have the strength to do it, so they do it. Determination and efficacy. So you have women, and as physicians and as health professionals, we see women who come collapsed in their in the consultation, and they're since 5 or 20 years of collapse, and nothing works. You can give them thyroid hormones, you can correct all their deficiencies, but if you don't correct testosterone deficiency, they stay in this collapsed situation. And then you give during 2 to 4 months, once per month, a testosterone injection with the protection of finasteride. And that one becomes brilliant. I've seen this over and over. A brilliant one can become an iron lady and have fighting spirit. And so I will explain how to treat this woman so that they finally feel better and they remain better as long as they take those testosterone injections. These women can suddenly become, I would say, prime minister, or they have the capacity. It's really impressive, the changes. But don't forget, I give it with female hormones, never with alone. And also for sexuality, testosterone treatment is very efficient. And we'll look into several studies and talk about the dosing, etc. And there could be sublingual testosterone can be given also periodically, and also for cellulite. And you see that testosterone enantate injections that were good for mental firmness are good also to decrease the cellulite, to get that sort of effect, of course, with protection of finasteride. And also, and that's important, daily thigh exercise. You will not have testosterone working on the muscles of the thighs if at the same time there is not exercise. And so this is a study showing that using a testosterone patch, you increase the thigh muscle area, you increase all the area that is fat-free, but you do not change so much the fat mass. For the fat mass, you need to diet and exercise. And to have efficacy to improve the thigh muscle, it's sufficient to have the testosterone in a physiological range. It doesn't have to be very high. So you don't necessarily need to give testosterone injections for that. But with testosterone injections, it may work better during a certain time. And here is just a study that I show you that by doing exercise for the legs in patients with rheumatoid arthritis, in women, you do improve the muscle thickness. And by exercise alone, and you also decrease the fat in the thighs. So combine that with testosterone, and you have a real winner to improve and to decrease cellulite. Interesting is testosterone can decrease angina pectoris, and here I'm picking up a very old study. These women were 81 with angina pectoris. They received testosterone propionate injections that has to be repeated every 2 days. And actually, that improves 75% of these women with angina, that they have much less of this angina crisis. So it's also efficient in these women. This is just to show you that already studies have been published in 1943. And what about rheumatism? Testosterone also decreases rheumatism. These are postmenopausal women, and they have active rheumatoid arthritis. And they received also intramuscular injections of testosterone propionate, but then every 2 weeks. So I would rather use testosterone enanthate that has a better efficacy. And that decreased the inflammation. Erythrocyte sedimentation rate was decreased. The joint pains were decreased. And also less patients that did not improve with rheumatoid arthritis improved. Less patients were unimproved with rheumatoid arthritis, so it has better efficacy. And this is really one of the treatments that works well. There was a very famous Dutch physician who had a large patients database. Patients went for them because they had rheumatoid arthritis, and he released them with testosterone. So general well-being is also improved with those testosterone injections. And then we'll talk about hirsutism, excess body hair. You see here excess body hair that you see here. This woman that I treated and had within 7 months very great efficacy for this lifelong excess body hair. She had to shave even as a young girl when she went swimming, for example. And I will tell how to treat this sort of hirsutism that seems to be relevant to anything. It's an association of hormone adjustments. And just to tell you that it may take a time. So you only not have improvements before 4 to 6 months. And after 6 to 12 months, you do have important improvements, and 2 to 4 years is almost all gone. But you need some patience as a doctor and a patient. Now, what about testosterone treatment for breast cancer? Well, look here. These are women before and after the menopause, and they receive testosterone implants. And during 6 months to 10 years duration of follow-up, and on general, they had about a 40% decrease of incidence of invasive breast cancer. And the authors point that testosterone has a direct effect on the androgen receptor, and by stimulating this androgen receptor, it blocks proliferation of breast epithelial cells. It also puts the bad cells, I would say, in apoptosis, that they kill themselves. And it inhibits also the estrogen receptor alpha, and thus breast cancer growth. So studies in primates and monkeys and humans have support that effect of inhibitory effect of testosterone. So I'm going to let here Suzanne Somers say some few words on testosterone. Suzanne is world famous for a lot of books that she wrote. I think it's more than 25 books, and about optimizing health. We just don't have to live and die normally, but try in the meantime to have a fine time. And she's really a health advocate. So let me let Suzanne talk here. Suzanne?
It's always an honor when Dr. Hertoghe asks me to speak at one of his conferences. So I thank you for the privilege, Dr. Hertoghe. I've written 27 books. My name is Suzanne Somers. And I have interviewed Dr. Hertoghe in so many of my books because he's just a wealth of information. He asked me to talk to you today for a few minutes about testosterone and women. And at first I thought it was sort of a strange request. And then I realized that women don't think testosterone is an issue for them, but it's about balance. The body is a system and the body wants balance. I like to do a visual. To be a man, as most of you know, is to have the ratio of testosterone to estrogen. Yes, you have estrogen. To be a woman is to have a ratio of high estrogen to low testosterone. But as we age and we decline in estrogen, as we start losing estrogen and having the symptoms of, sleepiness, sweatiness, lack of sex drive, all these things, eventually your testosterone as a woman becomes higher than your estrogen. And that's why aging women have those low voices. And there was an actress when I was a kid, her name was Lauren Bacall, and she had this real low voice. That was really that she was pretty much barren from estrogen and had way too much testosterone. Any kind of imbalance is not good. And one of the things that happens to us women as we age is when we lose our sex hormones, we can't feel sex, can't feel it. Not that we don't want it, we can't feel it unless you work with a qualified doctor who knows how, through lab work, it's individualized. It can't be guesswork. You can't just throw it at yourself or buy some over-the-counter kind of product. Through lab work, determine your exact deficiencies and put back exactly what you need and exactly the amounts that you need until you achieve harmony and balance. Once you achieve it, you can feel it inside. There's a lot of talk around America about my sex drive because I'm 74 years old and my husband and I have a robust sex life. The reason I talk about it is not to be shocking. The reason I talk about it is so others my age can realize it's not over. If you don't do anything, it'll be over. And the scientific community has so beautifully extended life extension. But no one's paid much attention except Dr. Hertoghe and doctors like yourselves to quality of life. I write about quality of life. Aging is about worn out parts. As the parts that wear out first are your hormones, that's the game changer, got to put those back. Then you decline in mineral balance and nutritional balance and other balance that create a lack of harmony in your body. When you put back in your individualized requirements, you get to feel like you felt when you felt your very best. So as a 74-year-old woman, I take estrogen every day of the month. I take it in a rhythm. I follow the lunar calendar. I take progesterone 15 days of the month, which is very important because estrogen is carcinogenic, but progesterone is anti-carcinogenic. I take testosterone every day because my body wants toward that. I take DHEA every day, pregnenolone, and melatonin at night. I feel perfect, really perfect. And so I think that testosterone plays a vital role in women's health and women's sexuality and in your well-being going forward to have quality of life. Thanks a lot.
Thank you, Suzanne. Very, very good. So it just shows how important it is really to treat a deficiency in a hormone, and certainly testosterone, and also in women. And I can tell you, I wouldn't give to women a female hormone treatment if it is not also testosterone added to it. DHEA is not sufficient. But we'll show that in the module, and it will be explained with some studies that give you an idea that you need also, next to DHEA supplementation with age, also testosterone in women. Now let's look at men. Men can become deficient with testosterone very early, as we will see. I've written a whole book on this, and I think it's one of the most complete books. In a sense, you have a lot of references, but it has tackles all the different male typical diseases like prostate hypertrophy, prostate cancer, urinary incontinence, but also sex life, erectile dysfunction, lack of libido, and things like that. But it also tackles everything you want to know and how to diagnose and treat with testosterone, with many different types of treatment. So you really have a good idea what to do. You can scan this code to get it, to know how to get it. So there's a whole gamma of things that are shown on the back cover. You can see all the different information that is given for that. Now, let's look at the frequency of testosterone deficiency. Well, testosterone deficiency is frequent in men. It's really something that is common, and we won't stay, I would say, real men with a lot of testosterone up to the end if we don't supplement, like Suzanne Somers said very well. You need to, you have a chance when you're aging, there's a possibility that it's not over, that you will be still have a good sex life, but also other things that you can perform professionally well, and that you can have romantic love and things like that. So, and we need testosterone for that. So it starts early, and it starts already between ages 25 and 30 years, although very little and very few in the beginning. When you look at these men, you would say, oh, they look okay, they look good. Some are older, some are younger. Well, all these men here are testosterone deficient, okay? They all are pale. Paleness is a typical sign of a pale face of testosterone deficiency. It's a lack of blood perfusion. But you know that this man, this young man is also testosterone deficient. His eyes don't shine much. He has flat hair, his pale face, and we'll see other signs. He also probably starting to get a little obese here. His bloated face can be due to testosterone deficiency. So every 4 seconds, that's a testicle that you see, and the testicle has Leydig cells that produce testosterone. Every 4 seconds, a man who is listening now to my talk here is irreversibly losing, on the average, 1 Leydig cell, 1 testosterone producing cells. He makes new cells, then our old cells die off, but the net balance is that he loses 1 Leydig cell every 4 seconds. And that means 15 Leydig cells per minute, 900 per hour, and something like 20,000 per day. And there's a study on autopsy study where young who died were examined and compared to older men who died, and you see that there's something like 700 million of those Leydig cells at age 19, and that very active cells, while at the older age, like age 70, there's a remaining of 200 million left, but those are lazy cells. They're not very active, not able to produce a lot of testosterone. So then the physical signs. Interesting is that we all think that men lose hair because they have too much male hormones. No, they lose hair when they're losing testosterone and proportionally having more dihydrotestosterone. So in the vertex here, when you examine the vertex here, that the men lose so easy, there's too much dihydrotestosterone. Dihydrotestosterone is the male hormone that gives the masculine characteristics, penis development, beard growth, body hair. And occipital hair that men keep easy, there's no difference in dihydrotestosterone and testosterone. And you see also in blood, they have higher levels of dihydrotestosterone, certainly higher than the testosterone. So the ratio between dihydrotestosterone and testosterone is in favor of dihydrotestosterone and thus of male pattern baldness. And there's an increased activity of this 5-alpha reductase enzyme that speeds up the conversion of testosterone to dihydrotestosterone. And something I know, because I lost a lot of hair here at age 40, and I had recession, was able to change the balance and safely have a lot of hair at age 64. But it didn't take so much years. It's in 3-year time, I recovered my hair by changing the balance. So male pattern baldness, when you look at a man with a lot of hair, he has probably good levels of testosterone dihydrotestosterone, but in the measure that it decreases the hair, there's a relative, the dihydrotestosterone does not necessarily increase. In me, it didn't increase, but what decreased in me was the testosterone. And so testosterone deficit permits dihydrotestosterone to have too much action and make men lose hair. Now, this is testosterone sufficient face. The face looks quite masculine. The eyes shine well. He has good color of his skin. And this is when he ages, testosterone deficient face. And what you see is flat hair. You see a thinning of the inner eyebrow. This part thins out. There is dry eyes. There are a pale face. It's paler. We don't see it so much here, but in general, it's paler. And there's a loss of firmness of the face. It can all be due to testosterone deficiency. And so less masculine face. There's a study showing that the more masculine the face looks like, and the firmer it looks like in the masculine, the more testosterone there is. Now, interesting is that men have become, over the thousands of years of evolution of mankind, have become less rich in testosterone. And that's not necessarily a good thing for their health, but it's maybe good for civilization. Here, when you study about modern and ancient human skulls, this is an ancient skull. And that is typical for high testosterone levels, a strong eyebrow bone structure here, zygomaticus strong, and a strong jawbone. And this is the skull of men today. You see, it's like smaller. It doesn't have such big jawbones. The zygomaticus is also smaller, and the eyebrow is getting away, the bone there. But this is typical for lower testosterone levels, and it is thought that it has helped civilization by decreasing testosterone levels in men. Men could live together easier without fighting and trying to get dominant and things like that. But it's not necessarily good for health, because lower testosterone levels are linked to more mortality and lesser health. So these are a typical outlook of an androgen deficient man. If he has been castrated before puberty, like in Italy, those singers, opera singers were castrated, they look like this afterwards. An aging man looks also like this. He's also castrated, not by surgery, but by time. Paleness. There's gynecomastia appearing in both, muscle flabbiness, and abdominal fat accumulating. And so the serum total testosterone here in 20 to 39-year-olds, if they have no metabolic syndrome features. So what is metabolic syndrome? Metabolic syndrome is having abdominal obesity with high blood pressure, more sugar, higher sugar levels, and so on, and high insulin levels. And if they only have zero metabolic syndrome features in age category, those that have higher testosterone levels. If they have one feature, like hypertension, for example, they have lower level. And if they have more than 4 features, they have the lowest level. And so 4 metabolic syndrome or more is here. In the middle age, it's the same. Those who have more than 4 metabolic features actually have the lowest levels of the age category. And those of the very old, the 60 to 79 years old, same procedure, lower levels. So that means that if you have metabolic syndrome, you're probably, as a man, testosterone deficient. So that's what happens. He will say, I think I'm beginning to look like my father. And this man will say, that's nothing. I'm beginning to look like my grandfather. That shouldn't be so. We shouldn't look like grandfathers and grandmothers. We should stay younger longer and delay all this period of time. And that one of the tools is to treat testosterone on time. Now, testosterone deficiency is also linked to more benign prostate hypertrophy. You see, this is normal prostate. This is benign prostate hypertrophy. What you generally find is that the estradiol levels are excessive when there's an enlarged prostate, but also that testosterone levels and dihydrotestosterone levels are deficient. And that is known since the 1940s. In the 1940s, Jan de Kruijf was an author, not a doctor, but a medical author. He wrote a book called The Male Hormone. And he wrote about that when you give testosterone and those who had a large prostate was better. They could urinate better, again, during a certain time, thanks to the testosterone. So what are the mental and emotional complaints in men? There are many. We're not going to go review all of them, but I'm going to say one thing here. is that the dominant complaints in what is used in academical world as calling the partial androgen deficiency in the aging male syndrome, so men who become partially androgen deficient, the chief psychological complaint is a depressed mood. So when a man is depressed, think maybe it's because of testosterone deficiency. The somatovegetative symptoms are 36% of the complaints they have. Our dominant complaint there is hot flashes and sweating. So men also have hot flashes. So if men say, look, I sweat in meetings too much, hot flash, low testosterone, you're almost sure that this goes over when his testosterone deficiency will be corrected with testosterone. Sexual symptoms are only 13% of the complaints, and the dominant there is erectile dysfunction. No man should have erectile dysfunction before age 80, or something's wrong with his hormones. But you need to, on time, intervene. Now, I just wanted to tell you that when men are testosterone deficient, it's not just a little thing. His personality changes. He feels that he's somewhere not like a man anymore, not fully, because he doesn't have good erections, and he seems to be much unsure of himself. He seems to worry more. He seems to get emotional outbursts too often. So you really need to treat him, because it really makes him suffer. And often men do not go to the doctor with these complaints because the doctors don't know what to do anyway. They had tried, and then the doctor said, oh, that's just psychological. Yeah, but psychologically, it be due to testosterone deficiency. So partial testosterone deficiency is associated also with disease in men. And I will show in the model, there's so many studies showing association of testosterone with disease that I picked in for the model. Mostly the studies that show that the lower the testosterone levels, the more there's a risk of disease. And here for Alzheimer's disease, for example, you have the free testosterone index. I will explain this in other presentation, but it's the amount of testosterone that's able to get inside of target cells. When you have a low free testosterone index, you have a maximal risk of Alzheimer's disease. But as each time you have an increase of free testosterone index, and the testosterone index goes from 30 to 180, for example, and optimal value is between 85 and 100 or 105, something like that. Well, each time you have a 10 degree in, you increase from 50 to 60 or 60 to 70, etc. There's each time 26% decrease in risk of Alzheimer's disease, each time. So there's a very little risk of Alzheimer's disease when you're in the top levels of free testosterone index. And that's one of the best lab tests to do. Check the free testosterone index. And also, the lower the testosterone levels are, even if they're within the reference range of the lab, the lower they are, the more there is atherosclerosis. So atherosclerosis is measured in the carotid arteries here in the neck. And you, with echography, completely safe method, you go and check. And if the men have testosterone levels that are in the lowest 20% of the values, so many of those values are still within the reference range, they are low normal, you have a 50% higher risk of having a thicker intima media that is the 20% thickest of the population of those men. So here's the adventitious intima media, that's a carotid artery, and you see that this thickness increases with lower testosterone, and this increase means atherosclerosis. Also, higher testosterone levels can also be linked when they're low to more ischemic stroke. For example, each 1 nanomole increase of serum total testosterone is a minus 2% decreased risk of ischemic stroke. Ischemic stroke is cerebral accident where there's not enough blood supply getting to a part of the brain because there's a blood clot. And so that makes that if a man is here in the upper, at 1,000 nanograms per deciliter, he's at the upper limit of the reference range, he will have a 48% decrease in ischemic stroke risk compared to a man that is here at the lowest level. And often men who are old get below that level. So also there's more overweight. So lower testosterone levels are more related to more overweight and obesity. You see, like when you see a man like this, suspect testosterone deficiency. And actually, the lower the testosterone levels get, the fatter a man becomes in general when you do studies. And so if this is the reference range of young men, and I remember that for older men, the reference range is lower. And this is a study on 400 men of different ages from 40 to 80 years. The risk of metabolic syndrome, if you're one standard deviation from the mean, so you're still within the reference range, is 1. And each time you increase the level, you go from one standard deviation higher, you have a lower risk of metabolic syndrome, 57%, 82% for here, and here almost complete abolition of the risk of metabolic syndrome when you're two standard deviations from the average of young men. So this shows the importance to have optimal levels. So you're probably safe for metabolic syndrome when you're high in the highest levels here. And all these other zones are unsafe. And the lower it is, more unsafe it is. So what are lab tests to do for testosterone deficiency? Well, there are lab tests to do, and I'll overview which lab test. But what I'm going to overview here is studies that show, and we already show some of the studies that show that lower levels of testosterone within the reference range are associated to more disease, meaning that it's probably testosterone deficiency at these levels. So this is 95% of men aged 20 to 30 years are in the normal reference range. That's a definition, statistical definition. And only 2.5% are below the lower limit of young men. And 2.5% are above. And when you look at that, the testosterone deficient levels between this range, there's only a minority of the levels that are deficient that are below the lower reference range. But the majority is at levels in the lower half of the reference range and maybe even above. There are studies showing that even above here, above the average, you might still have a too low level. Certainly if you're tall and have a lot of muscles. So I'm going to show you some studies that show that there are testosterone deficiencies also at higher levels than the average level of testosterone. So at testosterone levels that are below 770 nanograms per deciliter, studies have shown there's more risk of metabolic syndrome and of osteoporosis. Below 840, and that's usually the upper limit in of older men, age 60 or above, there's more mortality, there's more risk of aggressive prostate cancer. And then there are inverse associations, and some of those we saw, the lower the levels are, the more the risk is. So even if you're above the average, you still can have a higher risk than compared to men who are at the upper limit. So there's more dyslipidemia, there's more sugar problems, atherosclerosis, arterial stiffness, blood pressure are increased, more obesity of the abdomen, sarcopenia, less exercise capacity, more Alzheimer's disease. So basically, where is a man healthy? Well, apparently not in these levels. And you need apparently to be high normal. I wouldn't be so rigid. I would say adapted to the patient, because some men don't have much muscles, are smaller, they don't need so much testosterone. Men who are taller and more muscled might have to be here. So I will explain all the little differences so that health professionals and that the physicians can really find a way of doing best medicine. Now, what are the treatments to give for testosterone? Here too, I will focus first, before telling what different types of treatment can be given, I will focus on lifestyle. weight loss increases serum testosterone. And it doesn't matter what type of diet, a high protein diet with low fat or high carbohydrate with low fat, it doesn't matter. For 52 weeks, for a whole year, it increased the testosterone level 16 and 15%, depending if it's total or free, and no difference between diets. So weight loss is a good method. Now, it's not sufficient for weight loss to improve a lot of testosterone deficiency related complaints. For that, you need to give the treatment. But it's interesting that that already helped. And it's very easy to understand. When you have a lot of fat cells and you're obese, as a man, the fat cells will absorb a lot of testosterone and neutralize it so that it doesn't have any efficacy. When you have much less fat mass because you have done a good weight loss program, there's less fat cells and less testosterone absorption by fat cells, so that basically the patient can enjoy higher testosterone levels. Now, also interesting, and it's not a joke, it's a scientific study by a sports car. What do you think will increase a man's testosterone the most? The Toyota Camry wagon that is used car when it was, or a new Porsche Carrera Cabriolet? I would prefer this car, but there's a reason for that. And when you look at the study had done in 39 young men, and they had the option to go on this new Porsche or an old worn out Toyota of the 1919, that is already 16 years too old. And that, they did a 1 hour drive. What happened is driving the Camry did not seem to affect a change in testosterone levels. You see here, going highway or downtown, a little bit more highway, but not really any major improvement in testosterone level with a family car. Worn out family car. But when the young men drove the Porsche, they had a significant increase in testosterone levels. You see, downtown and highway, much higher levels. I did much better. I bought a sports car for my wife. I like colors, you know, orange. It's an orange Tesla Roadster. So when the car arrives, I get higher testosterone levels because of this orange Tesla Roadster. And then my wife comes out, it's a double boost of my testosterone levels. And I feel it. So do the same if you can. And check the testosterone levels before and after. There might be a good change. Also support winners at sports even. And we have now, when I'm talking, the football championship, soccer championship in Europe, and support a winning team. And if you want to have a winning team, for the moment, the Belgian team is actually on the world top since 2 or 3 years, actually, in the classifications. So here they're winning. They have won the 3 first matches already. And well, that helps my testosterone to be better. And here's the study of Bernard in 1998 already knew that fans of a winning team have after the sports even higher testosterone levels, while fans of a losing team have lower levels. Also, there are some drinks to avoid, and among that is alcohol. Alcohol is considered as a man's drink. Here's a real man's ale. Wow, why he looks masculine. That's in the beginning, okay? After a few years of alcohol, that's how he looks like. Less real man, feminization. And we'll talk why. There are a lot of female hormones in alcohol, but it also converts testosterone in the body into estradiol more in female hormone. So not, if you want to remain a man, restrict your drinking of alcohol. Don't drink every day and maybe just once or twice in the month. That's safe. Avoid eating foods and using cosmetics in plastic containers. I don't like plastic containers. Certainly not for something I'm going to drink or eat or put a cosmetic in. Why? Well, look here. There have phthalates. Those make plastic soft. They're used in a lot of things. in food packaging, these food packaging, are you really going to buy your healthy food in that food packaging? I don't advise you. Of course, those won't be a problem when you such a problem, but it will be a problem if you put a fat component in those type of plastic. Also, cosmetics. Wow, not good. Plastic bottles. Some of those have phthalates, and the toys of babies, yes, full of phthalates. Full. Why are we doing that? Save the planet, save the body, save the human body is also planet. And do you know that the shampoo that you put, it's fluid, it's very pleasant to put with, it's not the foam, it makes it more liquid. Phthalates make it more liquid. Almost all shampoos are full of phthalates. And it penetrates because when you put something on your head, there are little pits where the hair follicle gets out, and that accumulates the shampoo so that you have a maximum penetration of phthalates inside of your body. So in humans also, we're probably full of phthalates. They have examined the blood test of 3 of our health ministers. We have a lot of health ministers in Belgium: a Flemish, Walloon, a German, and then a federal. They have examined 3 of those ministers. Health ministers, and they all have phthalates in their blood. And so the higher serum phthalates are, the lower testosterone levels are in men. For example, in men aged 20 to 39 years, if they were low molecular phthalates, small phthalates, there were lower levels of testosterone. And each doubling of such a phthalate did about a 5% decrease in serum total testosterone. Some men have 10 times more phthalates, so that can lower quite a lot the testosterone levels. In men aged above the 40, there's also the DINCH phthalate, which is gives lower serum total testosterone. Each doubling of a DINCH gives a 3.5% lower testosterone levels. In men aged more than 60, like me, they have the high molecular weight phthalates decreases all different forms of testosterone, total, free, and bioavailable. And each doubling gives a 7.7% decrease in total testosterone. This means that having phthalates is even worse for older men above age, at age 60 or above. So I'm being careful for phthalates. So take also nutritional supplements. And usually everybody thinks about zinc, vitamin A. I'll talk about it, I'll show the studies, but let me tell you that magnesium can help also. Here are Italian men, and the higher the serum magnesium is in these men, the more testosterone that they have. It's proportional, and it's a strong and independent association. So stay on high magnesium levels, and I take every day high dose magnesium. There's also another thing, is that magnesium makes that the testosterone molecule that binds to the SHBG becomes looser. There's less binding. And in vitro studies show that actually the higher magnesium concentration was in these in vitro studies, the slower and less binding there was of testosterone to SHBG. That means that testosterone will be able to be more in the free form and penetrate the target cells easier. So magnesium, really interesting. More stimulates testosterone levels and also being in the bioavailable form for the target cells. Now, what are the testosterone treatment? I'll talk about here. You see that when you take a transdermal testosterone, you should apply a thin layer, not a thick layer, because there won't be more penetration with thin layer than a thick layer. And I will also propose that you give several layers. So let me show where I propose to put testosterone, not on the back, the skin is too thick, not so much on the belly or the arms. In the arms, there's too much body hair, but you should apply on body hair free skin areas. Otherwise, the testosterone on the hairy areas will convert to dihydrotestosterone. So the forehead is a good place. I put it here, no problem for hair loss. The neck, the sides of the neck, above the collarbones, there's usually no body here, so that's okay then. And the sides of the trunk. But mostly at these areas, because these areas are areas of high absorption, like the forehead the neck. Where you blush, there's more blood vessels. And you should apply 3 to 4 thin layers and rub in between each layer. So I will give a lot of practical tips. There are other tips to give. We'll talk about what happens when you take a shower or you put other oils like sunscreens on. And with studies, we'll have very practical information. There are also testosterone, intramuscular testosterone injections that I will abundantly talk, which are the best. There's the testosterone enantate or indecanoate or propionate or other forms, etc. So there's also a special presentation on synthetic non-bioidentical testosterone use of anabolic steroids in some cases. And I must thank my friend, Dr. Gianluca Pasaglia, because he's the author of many slides. And in time he lent me the slides. I've perfectionated some of them. And I'm not showing much of this because it's very well presented in presentation. You need time to present it well. But what I'll talk is that those anabolic androgen steroids, called also AAS, have the same action as testosterone, but they have a certain anabolic androgen ratio. Why did pharmaceuticals firm design anabolic steroids? Well, actually to have a form of male hormones that are less male hormone and more anabolic. And so there's a special ratio per molecule, the anabolic androgenic ratio. And for example, the anabolic androgen ratio of testosterone, bioidentical testosterone, is 100. But if for nandrolone, decadurabolin, for example, it's 37, at least for the androgenic ratio, meaning that there's less male hormone effects, more muscle building effects and bone building effects. And so we'll have different ratios and we'll talk about that. And then we'll talk about each molecule, and what are the doses, what are the risks, if it's good or bad for the liver, very practical information. So just to remember that anabolic androgen steroids are derived from either testosterone, 19-nortestosterone, nandrolone, or dihydrotestosterone. And for example, of the testosterone-derived steroids, there's non-bioidentical ones like methansprenolone or boldenone or fluoxymesterone. And there are also bioidentical ones that are like androl, cystanone, etc. Those are all brands that are have the normal testosterone. And the nandrolone-derived steroids, you have several forms, the nandrolone decanoate, nandrolone phenylpropionate, etc. Some are by injection, some by mouth. And then you have the dihydrotestosterone-derived steroids like oxandrolone and drostanolone and metanolone, but they make, they're too androgenic for some, and so you have male pattern baldness easier. But sexually, they might be better than the other ones, stanozolol and oxymetalone. I personally always prefer bioidentical testosterone, but there are some exceptions, so we'll talk about that too, where they would have a good application. Now, there's also another presentation with how to solve testosterone therapy problems and solutions, how to correct, for example, a testosterone deficiency that persists. You give a treatment, it doesn't seem to work. And we'll see all these different solutions. There will be complaints that are persistent, or physical signs that persist, or the test of testosterone stays low in the lab test, whatever you do. So we'll see what are the solutions for that. And there are many, many different options and depending on the situation. So it's really interesting to be able to do that, to become a physician who's very efficient. Now, how to correct testosterone excess despite testosterone therapy. We'll also see that actually the most frequent sign of testosterone excess or side effect of testosterone treatment is actually a high hematocrit. You have hematocrit above the 50%, you are nearly 4 times more risky. And we'll talk about how exactly to manage that. So it's okay. So this is really the most frequent adverse effect is the blood becomes too thick and can provide blood clots and embols in the lungs if ever a patient stays too high on this on hematocrit. And then we'll also talk very specifically how to correct estrogen excess, because that's one of the major problems that may occur during treatment, because testosterone can convert to estradiol. So if a man converts too quickly, that's a problem. A problem because it creates diseases. For example, here are some of the diseases, there's more, but it gives you an idea. You can have a low HDL cholesterol because of too much estrogens in a man, higher LDL, VLDL cholesterol, a higher triglycerides. You can have also more blood coagulation if man has high estrogen excess, atherosclerosis, arterial hypertension, coronary heart disease. So many blood vessel problem actually. And then, of course, easier myocardial infarction, or low extremity peripheral disease, where you have to stop walking as a man because there's not enough blood perfusion in the legs because of atherosclerosis in the legs. Stroke, varicose veins, easier also. Erectile dysfunction, gynecomastia, abdominal obesity, testicular atrophy, infertility, prostate hypertrophy, also easier with more estrogens, prostate cancer, and higher mortality. So this is really something serious to take and has to be corrected. I've heard that some feel better with high estrogen levels. Well, it's almost always due, in my experience, that they have other deficiencies, or if they take a blocker, the block creates other deficiencies. So you need to look elsewhere than just remain on high estrogen levels because of all these risks that you have here. So here, so a study showing that if you have a man has an estradiol level in the upper quartile, upper 25% highest levels, there's significantly more stenosis of the carotid arteries. If men have estradiol levels in the upper 33%, they have more prevalence of coronary heart disease. And it's mainly for heart disease, estradiol, high estradiol levels are worse than low testosterone levels. And for erectile dysfunction, men with erectile dysfunction have a 25% higher level of estradiol, while the levels of testosterone can be similar. And there's also more risk of prostate cancer. This study showed that 1 picograms per ml of serum estradiol increased the risk of prostate cancer by 4%. And you say it's not much. Yes, it is much, because the reference range of estradiol is maybe between 10 and 45 picograms per ml. So if you go from 10 to 45, you have to multiply this 4% by 35%, 35 times to get the higher value. So 20 picograms per ml of serum estradiol, which is a classical case of men with high estradiol have maybe 20 picograms per ml too high, well, it gives an 80% increase of prostate cancer risk. Specific treatment for men's disease will look over how to solve blood coagulation problems, arterial hypertension, because there's an adjustment of the dose of testosterone that may be different, coronary heart disease, acute transient myocardial infarction. How can, when a man has acutely myocardial infarction, you should give high doses of testosterone. It really helps. It can save him his heart because the muscle responds very well to high dose of testosterone. Acute enhancement stroke, that's one of my favorite treatments in stroke, high dose even in women, and it works. Erectile dysfunction, how to treat that. If the testosterone converts too much to estradiol, it's not good, so you need to adjust there. Peyronie's disease, where the penis has a curvature because of fibrosis of some areas of the penis. That is reversible, and I'll tell you how. Not in all cases, maybe, but in most cases. Feminized body is really a complaint we have with our men who come for the consultation. They want to get their masculine body again. Gynecomastia, breast formation. Testicular atrophy, what to do. How to treat also male subfertility. Prostate hypertrophy, and how to treat with prostate cancer. Adjust the dose or give not. But I think Professor Abraham Morgentaler will talk more. And then there are studies showing that, for example, one of the multiple examples, that men who are under testosterone intramuscular injections had in this study 7 times less risk of developing myocardial infarction. So it's really worth to treat men on time. So Professor Morgentaler will talk about the testosterone prostate cancer, and just to give you a little idea, testosterone levels decline with age with men. At the same time, prostate cancer incidence increases. That alone already should make us think there should be no bad link, actually, of no bad effects of testosterone that would promote prostate cancer. And here's a study showing that every 100 nanogram per deciliter decrease of serum testosterone, and the reference range between 300 and 1,000, there's a 31.5% increase in prostate cancer risk. And for 200 nanograms per deciliter, there's 63% increase of prostate cancer risk by lower testosterone levels. So questions that will be answered in the presentation of Professor Morgentaler will be, what are the risks of testosterone therapy in healthy men without prostate cancer? And what are the risks of testosterone therapy when you give it to men who have active or removed prostate cancer? So I'm finishing here my presentation, and just giving you a little overview that this is a free webinar, but it presents also a model of the whole evidence-based hormone therapy postgraduate program I'm presenting. And you can get more information by putting this sign on your mobile phone. And it presents, there's a model on how to treat all infections and stimulate the immune system, including COVID-19, inflammation and inflammatory disorders, a very large model of 8 sessions on reversing physical aging, very practical oriented, a lot of pictures before and after, female hormone supplementation, what to do, and also how to cope with breast cancer, chronic fatigue and burned out, very interesting. You get a lot of tools, a lot of nutritional therapies too, not only hormones, a lot of diet. And in most of my models, there is a lot of information on nutritional therapies and diet approaches. Thyroid diagnosis and treatment, very, very extensive with a lot of information, including on autoimmune thyroiditis, melatonin treatment with excellent presentations, also by world-known Professor Reiter, testosterone in men, testosterone in women. And we also have Spanish subtitles for the first 2 models already, and probably for the other models also in the future. So if you're Spanish, it may help also. Okay, so also discover a nutritional program. We have extracted all the nutritional programs to make a whole program itself. So if you're a nutritionist, that may be also interesting, and just scan this code to get into it. So here I'm back to Professor Morgentaler. I will stop sharing my screen, and Abraham, I will make you a host again so you can appear. Oh no, it's for the translator. Sorry. Yeah, translator, can you get out of the host position so I can get back to directing? Can you make me a host again? Galia, can you change this, please? Galia, I did an error for translator. Can you change again? Okay, thank you. And so, okay, I'll go here. So Abraham, can you put on your video? Okay, great. Thank you. Your audio is also on, so you can hear me, I suppose, no? Okay, Abraham, you were talking about how you started to investigate actually the link or the absence of a link between testosterone level and prostate cancer. You talked about the Professor Huygens that won the Nobel Prize. How did you really start? Why did you get interested actually in this link? Can you tell more about that?
Yes, so it's just an amazing story. So I'm a urologist by training, and I was specializing in sexual medicine. And this was in the late 1980s, and it was before the time of Cialis and Viagra. And when men had sexual problems, we really didn't have that much to offer them. We had surgery to put artificial devices inside the penis, but not a lot of people wanted that. And I had done research for 3 years with lizards, and my first testosterone publication was about lizards and sex from 1978. And, you know, in medical school, I didn't learn too much about testosterone. And in urology training, we learned that testosterone was terribly dangerous, that it caused prostate cancer, that if cancer existed, if we raised testosterone, it was like pouring gasoline on a fire or feeding a hungry tumor. But so some of my patients were desperate and they said, you know, you've got to help me. Is there something you can do? And so I started measuring testosterone levels and was surprised at how often they were low in men. Nobody had taught me that. And I wondered whether men might be like lizards, where testosterone was very helpful. And so I gave testosterone to several men and was surprised at how well they did for many of the things that you've just been describing over the last hour. But the big fear amongst urologists, especially because of the work of Nobel Prize winner Huggins, was that testosterone caused prostate cancer and made it grow rapidly. And so I really, because I saw the benefit of testosterone, to be safe, I actually started doing prostate biopsies in the early 1990s before I gave testosterone. And I did it just to make sure that they didn't have an existing cancer that would grow rapidly if I gave them testosterone. And the belief back then was that men with low levels of testosterone, like these men, should never get prostate cancer. That low levels were protective, and it was high levels that were dangerous.
It's a bit the opposite of what we think now, I believe. Huh?
And what we found was the opposite, that these men with low testosterone actually had a high rate of cancer. And today I can tell you that high-grade prostate cancer, the cancers that tend to be really problematic for men, are associated clearly in study after study with low levels of testosterone, not high levels. But that wasn't known then. And so really the way I got involved with it was really to just make sure that my men were safe, because I still believed the old teaching that high levels of testosterone or raising testosterone was bad. And it turned out to be the opposite. We published that in the Journal of the American Medical Association in 1996. That's a long time ago now. And that was really the first piece of evidence that the old belief that high testosterone was dangerous and low testosterone was protective. It was the first piece of evidence that that was not actually true.
And I think you went down to study what was the basis actually for Professor Huggins to declare that testosterone was carcinogenic for the prostate. And I think you checked the number of cases he was investigating, and then you came to a quite amazing discovery. Can you tell more about it?
Yes. So, you know, so in 2004, I published a review in the New England Journal of Medicine on the risks of testosterone. It was sort of the early days of the modern era of hormones. And just a couple of years after the Women's Health Initiative study that scared so many people falsely about the dangers of hormones in women. And what we wrote in there, which was surprising to me also, is that we simply couldn't find evidence that high levels of testosterone were dangerous for prostate cancer or testosterone therapy, even though this was being taught in medical schools around the world. We couldn't find the evidence. We didn't say it wasn't true. And I was on a panel once with another faculty member who was an expert in prostate cancer. And he said to me afterwards, he said, you know, your work is very interesting, but you better be careful because men with metastatic prostate cancer might be different. They have more tumor burden. And by the way, Charles Huggins, the Nobel Prize winner, and a very important individual in urology. He's our only urology Nobel Prize winner. So everybody knows Huggins. Huggins showed, he said, that testosterone makes metastatic disease grow. So, you know, his paper was from 1941. This was in the days, this is around 2005, 2006, before you could get articles, old articles online. And I was fortunate at Harvard to have the medical library there where we had old journals going back, Lancet into the 1800s. And I found the original article in the basement of this library, which was the only way to get it. and I read Huggins' article. And it's the original article. He deserves a lot of credit because he showed for the first time that any cancer could be hormonally manipulated. And he ended up doing work also with breast cancer and ovarian cancer and uterine cancer. But what he wrote in his paper was he created the establishment of castrating men, removing their testicles, or lowering their testosterone, which we now do with medicine, for men with metastatic disease. But what he also wrote was that in every case that he gave testosterone to these men with metastatic cancer, that the blood test he was using, which was called acid phosphatase, went up, which was bad. And so the final sentence of his paper says, testosterone injections activate prostate cancer. And I will tell you that when I first read that article, I was very nervous. I had many men on testosterone. Nothing bad had happened with prostate cancer. But Charles Huggins was a god, and he said it was dangerous. And I really worried that the police were going to come and take me away in handcuffs, and my picture would be all over the newspapers for somebody who's done something terrible to these men by giving them testosterone, because it wasn't widely done yet, at least not in the United States. And then I forced myself to read his article again. And you know, the articles back then were written differently than they are today. Today we start with how many men were involved in the study and how many men went to this arm and that arm, and they were done more like almost like case reports then, you know, a series of cases. And I told myself to ask certain questions of this article, like how many men received testosterone in this study by Huggins? It turned out the answer was only 3. Of the 3 men, he actually only gave results for 2 of them. One of those men had already undergone treatment to lower his testosterone. And today we know that's a special case. We call that androgen deprived. And so what it meant was that the entire general concept based on Huggins, it came down to one patient. And what he wrote about that one patient based on serum acid phosphatase levels, which we no longer use because they're not reliable, they're erratic, they go up and down, up and down. If you look at the curve for that man, one remaining man, the levels go up and down before testosterone, they go up and down during testosterone, and they go up and down after testosterone. It's not, you can't make any conclusions from it. And I was just shocked when I read it, because it really meant that the foundation for our belief that high levels of testosterone are dangerous was based on one man who received testosterone for only 18 days using a blood test that's not reliable, and where the results were not at all indicative that something bad was happening. It's just shocking.
Wow. And I think you also, in the course of the years, went into confrontation with other things. For example, there was a certain moment, an article, I think it's again in JAMA, that was published about cardiovascular disease and testosterone, and where they showed that testosterone was very dangerous for cardiovascular disease. By the way, I did research the literature, and I found, I think, something like 120 studies showing protective effects and only 6 studies showing adverse effects. But can you talk more about, because you have a, I would say, interesting story to tell there.
Yes. So, you know, for about 20 years, the data had been accumulating, as you mentioned, that testosterone was actually beneficial in terms of heart disease. And when I say testosterone, most of these were not intervention studies like testosterone therapy compared to placebo, but rather were observational studies with naturally occurring levels of testosterone. So men with low testosterone have more coronary artery disease, they have worse severity of coronary coronary artery disease. Meta-analyses have now shown that men with lower levels of testosterone die sooner, and 2/3 of deaths are usually considered cardiovascular in nature. And there were a couple of studies, observational, that showed that when men were given testosterone, that the mortality rate was reduced. That was the background, that was the literature until 2013. In 2013, in JAMA was a paper published, the first author was Vigen, V-I-G-E-N, and it was an observational study from the Veterans Hospital group in the United States of 8,500 men. And all these men underwent cardiac catheterization for presumed heart disease. And all of them had low levels of testosterone. And after the cardiac catheterization, some of those men went on to receive a prescription for testosterone, and some did not. Those are the two groups. And what the authors reported was that the men who eventually received testosterone had a higher rate of heart attacks, strokes, and death than the men who didn't. And specifically and it made headline news, at least in the United States, and I think around the world. This was a major surprise finding that testosterone might be associated with increased cardiovascular risks.
Now, we heard about that a lot in the newspapers here too.
Yeah, and I had patients who called me and said, my cardiologist called me up and said, I have to stop my testosterone. He said, it's going to kill me. So we had a lot of people stop testosterone then. They were scared. But, you know, the authors used a phrase, a statistical thing in their abstract, and this made it into all the stories. And what they wrote was that the absolute rate of events was greater in the testosterone group. And the nice thing about absolute rate of events for me, and for most, I think, clinicians, is that it's a record of what actually happened. So it's just the number of bad things that happened divided by the number of people. So let's say I have 100 men and 15 of them had something happen, it would be 15%. There's no adjustment for age or for anything else, which always makes papers difficult to interpret, right? But absolute rate of events is what actually happened. And what they said was that there was a higher number for the men with testosterone. But they gave all the information that you needed in the abstract and in the paper to calculate on your own what the absolute rate of events was. And it turned out that the rate of events was lower by half in the men who received testosterone. It was the opposite of what they had described. And so I have a few friends, you know, and colleagues around the world who are interested in testosterone. And when this paper came out, other people noticed the same thing. And we're all discussing by email, somebody needs to do something. We should write an article to JAMA. JAMA should give us space to write context for this. And somebody needs to call the editor. So I said, I'll call. And I called up the editor of JAMA. His name is Howard Bachner, and he's a nice man. And amazingly, he took my call. And we had a nice little conversation. And I explained to him, I congratulated him on his new article that was getting so much attention. This is about 3 days after it was published. And he said, thank you very much. And I said, you know, I represent a group of international testosterone experts, and these results are opposite what the data have shown for the last 20 years. And we'd really like to write a opinion piece or a context piece for your journal. And he said, unfortunately, we don't have space. We get a request like this all the time, but please write a letter to the editor. We take those seriously. And I had the impression he was trying to get me off the phone. And so I said to him before I go, can I just show you something in the abstract? He said, sure, I have it on my laptop. And I said, you know, it states that the absolute rate of events is higher in the testosterone group. I said, if you add up the numbers, which I've already done, and you can do it yourself, maybe you have a calculator on your phone, what you'll see is that the rate of events is approximately 10% in the testosterone group and 21% in the non-testosterone group. It's the opposite of what the authors are reporting. And there's silence on the phone. And I said, your authors made a mistake. Your reviewers missed it. The person who wrote the editorial for you missed it. I say, JAMA is putting out false information, and it's now been distributed by the media around the world. I say, JAMA has a responsibility here to what the truth is. And there's silence on the phone. And then after a moment, he says, I cannot disagree with anything you've said. He said, I'm going to contact the authors and I'll let you know what happens. Within a few days later, a week after publication, he sent me an email saying that the article has been revised. And when I went online, it had been revised without any mention, by the way, that the article had been changed from the original. And they left their numbers the same, but now they changed absolute rate of events in the abstract and in the paper with a very statistical mumbo jumbo, like estimated, calculated probability of events based on Kaplan-Meier curves, which the average person has no way of knowing whether that's true and what the reality is. So they changed it, but they didn't announce that they had changed it for several months. And in the meantime, of course, there was no media attention to the change. We did write a letter to the editor, and we made some criticisms of some of their methodology, and they'd excluded a large number of men, over 1,000 men, who should have been included, who they shouldn't have excluded them. And when they published the letter together with the reply from the authors wrote that we looked at our data, and it turned out that 9% of their population were women in this all-male group. Women. So imagine a breast cancer study of women where you find out afterwards that almost 10% of the people were actually men and were included by accident.
Yeah,
it's not a useful study. And so in the end, we had over 150 leading experts in 29 medical societies petition JAMA to actually retract that article, but they didn't. And so that article still gets cited as if it's evidence of increased cardiovascular risk. It is not. It's an article that should have never been published, and once published, it should have been retracted.
Well, thank you for the information, and you were very courteous. You also said that you never saw that an abstract of JAMA was changed afterwards. That's very rare, a phenomenon. There's also something important. We'll go back to prostate cancer, is that several physicians throughout the world, and I think you're one of those, that have started to treat prostate cancer patients with testosterone. And not only when the prostate cancer has been removed, but also if there's active prostate cancer. What are the results of that?
Well, the people sometimes say that I've been brave in treating some of these men, but really the courage is from the patients. So I've seen men who have asked me to treat them. Either they have experience with testosterone in the past, or they just feel poorly, and they have low levels of testosterone, and they've got prostate cancer. And I did this slowly. When I started out, I believed what I had been taught, that testosterone is bad for prostate cancer. And slowly and progressively, as I started treating men who'd been cured, appeared to be cured of their cancer from surgery or radiation, and I gave them testosterone and nothing happened. And then men who were on active surveillance, they have untreated prostate cancer, but they're just being observed. And I had men who asked me to treat them, and we published on all of these men, and nothing happened to them. Some men will have a recurrence of cancer, about 15% after surgery. Some of them on active surveillance will progress and have worse disease. But what we've shown is that the rate of progression of cancer is no different in men who get testosterone and men who did not. And the most recent work I've done, which has been published in part, and then there's another publication in 22 men who's now been accepted but will be published soon in the journal Androgens, is in men with metastatic disease. So, the history of that was that was who Huggins worked with. And the belief was, if you have a man with metastatic disease in his bones or in his lymph nodes, and you give them testosterone, or you raise testosterone in some way, that the cancer will go rapidly. Not that the rates will be different at 1 year or 2 years, but within 30 days or sooner, the belief was something terrible was going to happen to these men. And so I've had a number of these men, as I mentioned, who were desperate, whose quality of life was terrible. Some of these men were already on medicines to lower their testosterone, which is the standard treatment for advanced disease. And the first man who came to me was 94 years old, very smart, a scientist. His brain was still good. And he had the highest PSA I'd ever seen, which was over 500. We say normal is up to 4. If it's 10, we say that's very high. His was over 500. And he had metastases too, all over his bones. And he had nephrostomy tubes because he had blocked kidneys. And he came with his daughter from another part of the United States. And his daughter was what we call here a nurse practitioner. So she was very knowledgeable. And he said, I've read all your research and I want you to give me testosterone. And I said, why do you want it? He says, I'm too tired to do anything. I used to exercise every day and now I can't do it. And I used to write to my colleagues around the world by email, and I don't do anything anymore. I said, I've never treated anybody like you with testosterone, and, you could die tomorrow, a week from now. And he said, doctor, I'm 94 years old. I'm going to die sometime. And I know I've got advanced prostate cancer. I'm not afraid. I've never lived my life in fear, and I don't plan to start living my life in fear now. I'd like to live well for as long as I'm on this planet. So I offered him testosterone, and his daughter gave him injections every 2 weeks. And within 6 weeks, he was exercising. His appetite had improved. He'd gained weight because he'd been underweight before. He started writing with all his friends and colleagues. And he lived for almost a year on testosterone. And he had an excellent year. And during that year, he knew he was doing something special and that might be helpful to other people. And he encouraged me to use his story and his picture and his name. And so in my lectures, I often do show his picture. And it was amazing. And he started me. His argument was very good. At a certain point in life, what do we have to fear? We know we're going to die. Why not live well? And what I learned from him was that nothing happened suddenly. And he gave me the courage to treat men who were younger and also with some degree of metastatic cancer. Now, listen, I don't recommend to your viewers today that that's a simple thing to do or that they should do it. Some of these men will have progression of their cancer because that's what happens with advanced prostate cancer. And there will be many doctors who will say that you gave testosterone and you are responsible for the death or the complications. But what I am saying that in terms of understanding the problem scientifically, that the data simply do not support anymore, in my opinion, and in my clinical experience, that raising testosterone in these men is a serious problem.
Good. I think there are also two studies in the 1950s of advanced prostate cancer patients receiving testosterone, and it was also apparently increased survival at a certain time, but it didn't cure them of cancer. So if I find them, I will send those references to you. Okay, what I propose now, it's really fascinating. I really must say to the audience, I'm very grateful for you, Abraham, because you've done such a wonderful work, and it helps us all over the world, us physicians, to treat patients much better and have the courage to treat what we should. And I'm really following your data a lot. Here I have some questions. So I'll try to find the questions where we can also have you answering. I just have here a question, maybe it's more, maybe not your domain, but how can men stay fertile when taking testosterone supplement? In other words, how to balance testosterone, FSH, LH? The problem is that testosterone, even the gel, reduce FSH and LH. Can you comment on fertility or
Yes.
Yes.
Yeah, so I specialize in male infertility, and the problem with exogenous testosterone is that it suppresses LH and FSH from the pituitary. And so in general, we try and avoid exogenous testosterone in these men, and we use other strategies to raise testosterone. The simplest is clomiphene citrate, which is a pill. It's pretty good in raising testosterone. Not everybody gets as much of a physical response to it. Much more effective in terms of symptom benefit is HCG, human chorionic gonadotropin. The downside is that it's a injection that has to be given usually 2 or 3 times a week. So for the younger man who's trying to have babies and is otherwise healthy, that feels a little invasive, but it works really quite well. Raises testosterone, good for sperm.
Good. I have experienced that one of the problems is testosterone, it converts to estradiol, and the estradiol can then lower FSH, and then you have less spermatogenesis. And so we are very attentive that the estradiol doesn't get too high. That may be also helpful. And then in that case, I have seen that I don't have so much problems if I give a low dose of transdermal testosterone, like 50 milligrams, but if it's more, then it creates a problem of more suppression. Then let me see here. That's a question. Maybe you could also answer this question. Do you treat just by symptoms, or do you get testosterone levels as well?
I get levels. I get levels in everybody. You know, one could make an argument, and maybe you believe this, Terry, that with a good history and examination, that we really can reliably identify the individuals who are deficient in testosterone. I think most, with an experienced clinician interest in this topic, probably that's true. You know, I work in a fairly litigious country. There's a lot of lawsuits and there are a lot of rules, and I've broken many of the rules, particularly around prostate cancer. So I actually need to be very careful about everything else that I do, and I get blood levels in everybody.
Yes, I do too. Systematically, it also gives information on other aspects like too much estradiol, and so it does really. And we also ask the androstenediol-gluconide, which is a marker of activity of dihydrotestosterone, because some men may lose their hair if they have testosterone, they convert it too quickly, and then that's a marker. So lab test is fundamental. We are in a country where there's much less litigation, but the medical boards are as fierce as yours, so we have to be careful. Well, this is a question maybe I have to answer. What is the dose for topical testosterone for women around the rate for incontinence? Usually it's around the 0.5%, and it's a cream that we give. Now, not a gel, because the gel could be, that's alcoholic, could be burning. So we just ask the woman to put some thin layer of topical testosterone, and then to make 10 contractions with the bladder each time, and they do it once or twice a day during 6 to 12 weeks. In general, the incontinence is much decreased or finished. Okay, Oh, well, some of those questions I cannot, this pill in would, yeah, there was a question about the pill that decreased the male hormone. There are pills that decrease the polycystic ovarian syndrome. I showed a pill that decreases a lot the testosterone, more than others, and also block the androgen receptors. And that's a pill that is also given for acne, unfortunately. And when women have excessive body hair growth, not only in polycystic ovarian syndrome, which is related to more hair growth. That's a question in Spanish. In which patients can testosterone cause depression? Do you have any information on that, Abraham? I don't have information on testosterone causing depression, but it's true that in women, not in men, when the levels are too high or too low, there's more depression. So I think an overdose in women where the testosterone makes her look like a man will make her depressed. It's mainly that, I think. It's not the testosterone itself, it's the results of having masculinization that causes the problem. Or do you have any other information? Not really.
Well, I don't believe that testosterone causes depression in men.
No, it's just in women, if they get to look more like males, that can give, but that's an indirect effect. Would you give finasteride even if the estrogen is normal? Finasteride is not given to lower the estrogen levels. Finasteride is given to lower the dihydrotestosterone level in male pattern baldness or in female pattern baldness, for example. So it lowers the conversion of testosterone to dihydrotestosterone, and it's not an aromatase blocker that blocks the conversion of testosterone to estradiol. So it's a little error here of one of the patients from, I think, Italy. What about to use Nebido? Do you have experience with testosterone indicanoate, the 1,000 milligram?
Yeah, so, Nebido, which is a long-acting injection, is available in most countries in the world. In the United States, it has a slightly lower dose. It's usually 1,000 milligrams everywhere, Nebido. In the United States, it's 750, and it has a different name, which is Avid. But what's nice about it is that it's a long-acting formulation. So there's a certain range of how often you have to give it, but in Europe and South America, Nebido is usually given every 3 months. So that's pretty good. In the United States, it's every 10 weeks. It's a little bit shorter, but it's a very nice, stable way of providing testosterone for many men.
So I think it's good, but I have seen that on the average, 1 on 5 men seem not to have a good libido with it, and it seems to cause erectile dysfunction, which I don't much understand how. And so it's not for all men. And then my experience is that you need to give it at least every 2 months or every 6 weeks, but every 3 months, it's a little bit too late. The levels go down too much. And so I think it's not long acting enough to give it every 3 months. That's a personal experience. And then here, another question here is, that's for female. What do you address issues with erectile dysfunction as side effect of finasteride? Do you have an answer, or you want me to answer it?
Well, I think, for men with finasteride, my specialty is with sexual dysfunction. Yeah. And so we do see some cases where finasteride can cause sexual problems for men. It can cause difficulty having an orgasm, anorgasmia. It can cause decreased libido, and it can cause erection problems. So, the data on this suggest from the original studies when finasteride was approved that the rate is lower than 5%. I suspect it may be a little bit higher. And what's scary is that there's some occasional cases where even when you stop the medicine, it doesn't get better. So, DHT also has some sexual effects, it appears. And even though finasteride lowers DHT and in theory leaves testosterone levels alone, it appears that some men are vulnerable to this. And the challenge around some of this is that often the effect is delayed. So I've seen men who, after a year of being on finasteride, will say, I'm just having trouble having an orgasm. And if we stop the finasteride, I say, it could be the finasteride. They say, doctor, I've been on it so long. But if they stop it, some of those men will actually regain their original ability. So, you know, I'm in a practice as a urologist where we also treat a lot of BPH or enlarged prostate, you know, voiding symptoms. And finasteride is a pretty good medicine for that. But I try and stay away unless the man is less sexual or older in general.
Yes. So finasteride, for the public, is a progesterone derivative. And finasteride not only blocks the conversion of testosterone to dihydrotestosterone, but as a progesterone derivative, it can block LH. That means that the pituitary cannot stimulate the testosterone synthesis as much. So there will be lower testosterone production. So there are risks. I never give finasteride to a man or to a woman without testosterone. And generally, finasteride helps to regain hair, male pattern baldness, but only with testosterone. It's much more efficient to regain male hair on the upper scalp if you add testosterone, but on the condition you don't increase dihydrotestosterone. And so what happens when these men who take finasteride with testosterone get erectile dysfunction because of the finasteride, because it really can cause that, I propose them to take something like 30 to 50 milligrams more of testosterone, and that solves the situation. The erectile dysfunction disappears. And so that is really very helpful. So it's you need to have more testosterone when finasteride causes erectile dysfunction. I also would add that I would never give to a patient finasteride alone. Never. To women and men, never. Because I have cases of men who have taken finasteride for male pattern baldness, and that's not a high dose. And they came with Peyronie disease. You know, that's a sort of curvature of the penis with some fibrosis. Other with erectile dysfunction. There was another, with finasteride, we had also the problem of when it's not taken with testosterone, that you have sort of inflammation of the scrotum and the testicles. I even had one patient who didn't want to wait. He got his testicles removed just because of the inflammation caused since he took finasteride. So it was a little stupid because I really think he should have taken the time to take testosterone after finasteride. So we treat a lot of patients with finasteride problems and with testosterone with very good results. But once you have a problem with finasteride, sometimes it's better not to take it anymore. There's a question here, general, any medical doctors to recommend the United States East Coast to address female hormones and thyroid with similar competency to Dr. Hertoghe? I think there will be a whole series of clinics, and there's probably one already going to open up, who will address the female hormones. And there are many already hormone therapy clinics on the East Coast. I don't know them all, but I know some is going to follow maybe improved methods. What is the treatment to lower or eliminate the benign prostate hypertrophy? Maybe I can answer the question, and maybe you can answer also. So when I have a patient with benign prostate hypertrophy, the literature shows that it's usually due to high levels of estradiol that stimulate the proliferation of fibrous tissue in the prostate. So the more estradiol, the more female hormones. So I do give a treatment where I correct the estrogen levels that are too high in these patients, but I do also local treatment. The natural treatment that reduces estradiol levels is progesterone. So I give in suppositories progesterone 100, 150 milligrams per day. And I give it with an antiseptic that is used in surgery called Ictiol, and as 300 milligrams. And those suppositories within 6 months, 6 months time, reduce the the enlarged prostate by 20 to 40% in my experience. This is very frequent. I also, when there are risk of prostate cancer, and that is shown by a ratio of low free PSA and high total PSA, in these patients, I give a suppository of all the nutrients that have been shown to have anti-cancer effect for the prostate, like selenium, coenzyme Q10, and things like that. And that seems also to improve the ratio free PSA to total PSA. So do you have any more information about what could be done for benign prostate hypertrophy without surgery?
You know, it's very interesting for me to hear your approach, Thierry. You know, the standard, treatments for this as urologists is we use alpha adrenergic blockers, medicines like tamsulosin, alfuzosin. We can use finasteride or its cousin dutasteride. And actually daily Cialis has actually been shown to be moderately effective for urination symptoms. Testosterone itself as a treatment in men who are testosterone deficient has been shown with urodynamic studies to show actual improvement in the flow of urine, the reduced leftover urine in the bladder, we call post-void residual, and improved symptom scores in many men. Not all studies show it, but some men clearly are improved with testosterone therapy itself.
Yeah, that's also my experience that testosterone alone can help unless it converts too much to estradiol. So we're very careful to ask the patients not to drink coffee or drink alcohol, because those increase estradiol levels. 2 cups of coffee is an increase on average in a Greek study of 60% of estradiol levels, which promotes enlargement of prostate, and 1 glass of alcohol per day seems to have the same increase of estradiol. So we're very attentive also to improve the diet, but the testosterone, it's true that really works. Here's a question in Spanish. I will translate in English. Why does Dr. Morgentaler use pellets, or is it injections? And because it's, I think it's from Mexico, a doctor, he has a good experience of pellets. And what do you find about pellets?
So I use a wide variety of treatments for men, and we really individualize this. So I've done a lot of work with pellets, and the advantage of pellets is that it usually lasts about 3 months with good levels. I agree with your comments before about libido. It doesn't always last that long, but the pellets usually do. The downside is that it's a little procedure. You can get pain and infection, and sometimes the pellets come out, but overall I think it's safe and it's quite good. But we use the gels and the topicals and the short-acting injections, and we teach people to do their injections. And there's a nasal gel in the United States that is very interesting. We use HCG injections. We use Clomid sometimes. Am I missing something? The one thing that I don't use is the patches. The patches that are available in the United States are not very effective, and it causes a lot of skin reaction. And there's now an oral testosterone, decanoate. In the past, oral testosterones were thought to cause liver disease, but the new ones that are testosterone undecanoate don't go to the liver immediately the way the old ones did, with what's called a first pass effect, where they get high concentrations in the liver. These are instead are absorbed through the lymphatics in the intestine, small intestine, and appear to be safe for the liver and with good testosterone levels. One of the issues in the United States that is major is the cost of medications and whether or not they're covered by insurance. We have a very bizarre healthcare system in terms of what gets covered and what doesn't. And so we often have to choose for the individual patient the right treatment based on what's acceptable to them, whether they want a short-acting or a long-acting, whether they might be interested or willing in a pellet, which is great for somebody who travels a lot, for example. He doesn't need to carry medication with him, and what their insurance will or will not pay for.
You're an expert in sexuality, and I think they use also sublingual testosterone to give a push just before sexual intercourse. Have you experienced in sublingual testosterone?
So there is a sublingual, these troches or troches that are made by some of the compounding pharmacies. It doesn't last very long. The problem with most of the oral testosterone is that it's metabolized very quickly. So there may be a little quick bump, but most of the men that I'm seeing who are symptomatic, what they really need is they need their levels elevated into a good range throughout the whole range of time. And I'd rather do that than give something that'll work for 30 minutes if it works well at that.
That's more an addition in case they will have sexual intercourse. They just add a dose. Okay, we'll have one or two more questions because then we'll have to stop. There are pharmacokinetic. It seems that giving much lower doses of injection more frequently would be better to reduce aromatization, the conversion of testosterone to estradiol, and less swing symptoms. They have more stable effects if you give, for example, an intramuscular injection every 2 days with a lower dose than every 2 weeks. What is your opinion about that or your experience?
I think probably for most men, the optimal interval is weekly. You know, there's some men who do injections every day. I mean, we have some of those men, and the goal has been to avoid the ups and the downs, what we call a roller coaster effect. But for most men, a daily injection is just too much. Like they're just not willing to do it. And I think it's unnecessary. The half-life of the injectable testosterone is long enough so that at most twice a week, in my opinion, is more than enough. And most men will do very well with weekly.
So the one you use is testosterone enanthate or cypionate, or?
Well, we use both. Sometimes the choice is again determined by insurance. Their pharmacokinetics are almost identical.
Yeah.
And you know, both of them create an ester, a little side branch on the testosterone that once it reaches the bloodstream, it becomes cleaved, and then it releases the same identical testosterone as the one that we make.
Yeah, I think those are the two best, actually, intramuscular. Then maybe we'll end with this question. If testosterone is normal for my age and no exogenous supplementation is done, but estradiol levels remain high, so his problem is not low testosterone, but high estradiol, and he's taking a lot of plants like dim, maca, hesperidin, grapeseed extract. What are methods are there to lower estradiol in men? Well, the methods we'll amply talk about that in the model is actually that you can improve with the diet. You stop the coffee or the caffeinated coffee, you stop the alcohol, and those are two main things. They also, if men put underwear that is too tight, it puts the testicles against the body, and then the blood flow is not good. And when there's a low blood flow, testicles make more estradiol, less testosterone. And so there are little, and also I make patients lose weight because the fat tissue converts the testosterone to estradiol. So if your only problem is to lower the estradiol, you probably have to lose weight if you're overweight. So there are many of those things. Do you think of any other things? Do you concentrate on also on high estradiol levels, or you don't really take that into account?
So, you know, in my opinion, there's a lot of attention on estradiol, and I know that a lot of people are concerned about higher levels. The main time that it comes up for me is because when we give testosterone, when we raise testosterone, everybody's estradiol level will increase. Estradiol comes from testosterone in men and in women, at least one of the major pathways. And so some of it's aromatized. The issue with general health issues with elevated levels of estradiol, I'm not certain are the same if the elevated estradiol comes from testosterone therapy. You know, one of the most common high estradiol comes from more aromatase activity. Aromatase is the enzyme that converts testosterone to estradiol. And where do we see the most aromatases? In fat tissue. So in many studies public health studies, where they're looking at the relationship of, let's say, naturally occurring serum estradiol levels and whatever outcome they're looking for, heart attack, whatever, they're looking in naturally occurring levels in people, and they may adjust for BMI or other factors. But one of the issues is that no matter how good your statistics are and how much your adjustment is, there's always what we call residual confounding. You can never do away with all the known risk. And it's my opinion that the most likely explanation for high estradiol and many of the negative associations is actually through obesity. We know that we have a big problem, especially in westernized countries, especially in the United States, with obesity. We know that there are terrible negative effects of obesity. And the question is, how do we separate those out in studies from some of the consequences, which can include elevated estradiol levels? And I'm not sure that we can do it adequately. So in men on testosterone, I don't worry much about estradiol unless it becomes very high or they get symptomatic with gynecomastia or breast tenderness. If I see a man who's otherwise healthy, doing well, asymptomatic, and his estradiol is somewhat above normal, I don't treat him. But I'll treat him if he develops some problems.
So you would be reassured if you give testosterone, if the levels are high enough, that's protective against the high estradiol levels, if ever there's a need for protection. Is that your thought also, that by giving a testosterone treatment, if there's enough testosterone, they will be protected against?
Well, I mean, this is just my opinion, but my opinion is that high estradiol levels by themselves are not usually the actual problem necessarily. It's often associated with something that's increasing the estradiol. And the most common thing for that is obesity.
Yeah, sure. Good. Thank you. We're going to stop here. I must really thank you, Abraham, for all the work you've done, not only of responding here, but all the work you did before, because I think a lot of physicians really recognize your courage, because it's not only your patients, it's also your courage. And we're really happy that you're around there. So thank you. And you can now, I will close now your video and think, but really thank you. And I think the people have enjoyed. I see a lot of questions. We have too much questions, so we won't be able to see them. But thank you for being there.
It's my pleasure. Good luck.
All right.
Thank you.
Okay, so I have some other information to share, because we're going to have a new webinar in September. And so let me show you my screen. And here. So the next events that we'll have on June 23, that's tomorrow, I'll have a question and answer session for those who are members of the postgraduate program. In September, on the 7th Tuesday, we'll have a free overview webinar. We'll get a lot of interesting information of a whole new cycle of webinars. So I think that's really a date to retain for those who will be there. And so it's on cycle 2 of the evidence-based hormone training program. And there's a lot of nutritional programs also. There are books also, Hormone Handbook, Testosterone Therapy for Real Gentlemen, but really an in-depth book with a lot of also technical information, practical information, Reversing Physical Aging book, which are really books that really make a difference, and the Atlas of Endocrinology for Hormone Therapy. So you can have an overlook of these books and even buy them on hertoghemedicalschool.eu website. There's also, for the general public, hormone solution for physicians and general public, a book on oxytocin. It's really one of my favorites, the Patient Hormone Handbook. And then we really want to thank our partners. We have Hertoghe, Diagnost, Labophar, Access, a very active laboratory, Laboratoire Réunis, Laboratoire CopMed, EuroHealth, TerraScience, LIMS, Bionourisso, that have helped for the translation in Spanish, Forthaus Apotheke, Energetica Natura, really very helpful, Laboratoire Optimum, Longevitat, etc. Saudavel, which is the famous Brazilian group that has a lot of very interesting sessions. University Compounding Pharmacy is on it, NP Compounding Pharmacy from Greece. So we're very thankful for them, because they make it help to come true. And special thanks for the Spanish translation for the Instituto de Capacitación of Mexico, and especially Galia Irigoyen Cerecedo for the translation in Spanish. Really, thank you, and thank you. Here are all the contacts you can have. If you want to go on Facebook, LinkedIn, this has been on the same time on Facebook and LinkedIn, and then this is if you want the address of the website and the email if you need to have questions or you want to get into contact with us, get other information, registration, etc. Really, thank you for being there. It's really a pleasure. I'm really surprised that the number of people are registering and seeing the videos and the very good comments. I thank you, because this cannot also come true without you. I really thank you, and I hope you enjoyed it. Bye-bye.